Thanks, David and Emma and the rest of the atypical aHUS UK team for this invitation. As David said in the last talk, I actually do an awful lot of work in the laboratory, and it was actually quite a difference but pleasure to do some work looking at a clinical database, looking at patients who developed atypical hemolytic uremic syndrome in the setting of pregnancy. And what I'm going to try and do in the next 15 or so minutes is to convince you that it is a problem worth looking into, that it's not just those one or two patients out there, and that hopefully we can learn from this group of patients, perhaps not from the work I've done so far, but for ongoing work that may stem in the future. We've already heard today about what we generally think of in terms of atypical hemolytic uremic syndrome as being a disease characterized by an excess complement activation. We've already seen those overlapping circles, which we see in the next diagram, that you probably will have some kind of predisposing significant variant. You'll probably have some kind of adverse modifying variant, so these risk haplotypes that Professor Goodship just talked about. And in spite of having one or both of these, you probably need some kind of disease trigger as well. So that, just to remind us, you've got to have this significant rare variant, perhaps a more common modifying variant, and as I say, this trigger before you can get disease, or in this case, atypical aHUS. You've just seen one of those busy slides from David just before. There are lots and lots of different triggers. Many of them actually cause complement activation, and these triggers overall are indeed very common, and what we know is that they can only cause disease if there is sufficient underlying risk. And for many years actually, different people have said, oh, pregnancy might be a trigger of atypical aHUS, and perhaps the bigger question is this important? How important is this single trigger? When we actually think of pregnancy and medical problems, atypical aHUS is actually way down the list. The most common medical problem in pregnancy is something called high blood pressure, hypertension, and around 10% of patients will have this. So if you think of the World Cup team out there in the World Cup at the moment, on any single team, in terms of those numbers, one of those will have high blood pressure in pregnancy. There are many other problems in pregnancy in terms of medical problems, but some estimates suggest that atypical aHUS is only affected in 1 in 25,000 pregnancies. So that's not one in one team, that's one in the entire stadium of people watching these footballers. So is pregnancy important in atypical aHUS? Well, I think it is. A few years ago, the French group, also similar to our group in Newcastle, they actually published some data looking at patients with atypical aHUS, and what they did was to look at, across their database, over about 8 to 10 years, they found 100 female patients who developed atypical aHUS. And what they found was that 21%, so that's 1 in 5 patients, 1 in 5 female patients who developed atypical aHUS actually had disease associated with pregnancy. So if you think back to that football team, suddenly 2 members of that football team developed atypical aHUS in this manner. Suddenly, pregnancy seems far more important. So what I'm saying is that pregnancy is actually probably a relatively common trigger in albeit a very rare disease. And what I wanted to do was understand whether we could learn anything from this particular group of patients. What we did in the last year was to study a UK group of atypical aHUS patients and identify those who developed atypical aHUS either during pregnancy or in this short time period thereafter, what we call the postpartum period. And what I was interested in finding out was, do these patients all have these predisposing genetic variants, these rare significant variants? Can I read into any relationship between the pregnancy itself and atypical aHUS? I was interested to know what happens to these patients. Do these patients all indeed have complement genetic mutations that we've been hearing about, and do they all have a poor outcome like we would expect from many years ago? So what it did, we have a database of these patients in Newcastle. So these are patients who have developed atypical aHUS and their clinical data, and their DNA has been sent to Newcastle for further study. And what it did was to identify patients of childbearing age. We were able to contact many of the local clinicians around the country, and with their help and obviously with the consent of the local patients, we worked out which patients had disease in association with pregnancy, and then we were able to collect both clinical data and basic laboratory data to try and understand the course of disease in these patients. Importantly, of course, we needed some DNA, and in most cases we already had this, to screen for mutations or these rare genetic variants in the complement genes. This is what I found. We found 24 women in this cohort over about 8 to 10 years, and they presented on an average at an average of about 30 years. And that range, the youngest patient was 23 and the oldest was 38. And what's important to note is that these are patients who are generally diagnosed in the time before 2014. So the experience of this group of patients is mostly in a pre-eculizumab era, and you'll see that in the outcome of this cohort. I'm not going to show you all of the data from the work I did. I'm going to show you some of that data. And the first thing I want to impress on you is this chart, which discusses the kind of genetic rare variants that we find in these patients. And as you can see, the majority of patients had a mutation in one of those 5 complement genes that David talked about. Most were in factor H, a few more in factor I, and also CD46. Some had mutations in 2 genes, and of course a handful had genetic changes in C3. The next thing I was interested in is that relationship between pregnancy and onset of disease. This is a bar chart that shows the number of previous pregnancies that a woman had had at the time of onset of atypical aHUS, or rather when we first recognized atypical aHUS. Now, if pregnancy is that important a trigger, why is it that in only 7 patients who developed aHUS would develop atypical aHUS in their first pregnancy? What you can see is that the majority of patients, majority of women who develop atypical aHUS actually had got through 1 pregnancy, some a second or a third, before we find out that they had atypical aHUS. Are we missing something? It's worth noting at this point that in those patients who had had a previous pregnancy, around half had had some kind of problem related to pregnancy, whether it be preeclampsia and in some cases miscarriages. The next thing I looked at was when atypical aHUS developed in the context of that particular pregnancy. So I've divided this particular graph into trimesters, so the first, second, and third of pregnancy. And as you can see, a handful of ladies developed atypical aHUS in the middle of pregnancy, and a handful towards the late part of pregnancy. But by far the majority of cases of patients actually develop atypical aHUS after giving birth. And you heard in David's talks some of the ideas there that in that period after delivery, blood loss, perhaps, infection, perhaps, there's clearly something going on around that time point which is more important. Just to summarize that first part of the talk, clearly patients in this group do have predisposing complement risk variants, and striking that the majority of patients did not have atypical aHUS triggered by a first pregnancy, and that most cases of disease were triggered after delivery. And some of the questions that spring to mind, well, why don't they develop it in the first pregnancy? Is there a different risk from each one? Why is that risk different? And as I say, what is happening differently from early pregnancy to late pregnancy and postpartum? And these are some of the kind of questions which you try and answer. Okay, so what happens to this group of patients? These patients present with really quite severe renal disease. As you can see from here, over 3/4 of patients required dialysis in their initial presentation. So when they first came to hospital feeling unwell, they found to have kidney failure, the majority of these patients did require dialysis. And what kind of treatments could we give? Well, remember this was mostly a pre-eculizumab era, and the best treatment we could give was plasma exchange, and most patients received it. I'll talk about that one patient who received initial eculizumab in a short while. Despite what was at that time the best treatment, you can see that almost a half of patients, or 40% of patients, did go on to develop end-stage renal disease. So these are patients who require dialysis. These are patients who we may have thought about having kidney transplants, obviously in the 5-10 years past. And indeed, of those patients who went into end-stage renal disease, 5 of them were transplanted. And it's perhaps of no surprise that, given that we found that all of these patients had a factor VIII or factor I mutation, so these are 2 genes that are responsible for the brakes on the complement system, that because they had these mutations, the disease came back in the kidney transplant. And in all 5 patients, there was recurrent disease and the graft failed, and these patients ended up back on dialysis. I mentioned about eculizumab. One of them received eculizumab at disease onset, so that's very early on in the time course. And one of them, obviously who wasn't in that initial pie chart, did go on to receive eculizumab later on during her clinical course. She actually had relapsing disease, and in this particular case, giving eculizumab later on was actually effective. To summarize that second part of the talk then, we see that many patients require dialysis, so it's a very severe disease that these patients are getting. Almost half do go on to progress to end-stage renal disease, and I think very strikingly, all of these patients lost their kidney transplants. What would I do about someone who presented with atypical aHUS in the setting of pregnancy? You saw from there that they behave like all of the other patients that we used to see with atypical aHUS and complement gene mutations. I would refer them to Newcastle for genetic workup, looking for these complement genes, although now we'd probably start looking for many other ones as well. And I would suggest that they probably would be candidates for eculizumab treatments. And of course, now with the National Service, it's something that we could certainly think about, although at this time, I'm not aware that anyone has actually required this since the onset of this study. The next question you may wonder then is eculizumab safe in pregnancy and in the postpartum period? And what I would say is that the majority of the experience of eculizumab in pregnancy and in the postpartum period has been in a disease called paroxysmal nocturnal hemoglobinuria, and I heard one person reference it earlier. This is a disease of the blood in which complement is harmful to all blood cells. When you get harm to red blood cells, for example, they die and become anemic. And sometimes complement can be harmful to some of the other blood cells, and these patients actually get very severe clots. And in this particular disease, where eculizumab has been available for use for several years longer than atypical aHUS, eculizumab is indeed thoroughly recommended and indeed given during and after pregnancy. So it suggests that it probably is okay to give. There are some other studies in the laboratory which I won't go into in detail. And just to echo that, obviously we are starting to think about the use of eculizumab in atypical aHUS. Here we're just going to talk about the first use of eculizumab in pregnancy that was reported in the literature, where one patient actually presented with a relapse of her atypical aHUS midway through pregnancy. She subsequently received eculizumab and ended up with a healthy live birth. Of course, eculizumab in pregnancy as such is probably less of a concern because we already know that most of the cases of atypical aHUS present after pregnancy. To conclude, hopefully I've shown you that within patients with atypical aHUS, and in particular women, pregnancy is actually a reasonably common trigger. However, it does not always trigger atypical aHUS, though when it does, it is usually postpartum. We've seen that patients often do have these rare predisposing genetic variants, and the outcome in this particular group of patients was poor, as you would expect in a pre-eculizumab era. I've not got the answers to why exactly pregnancy is a trigger. There are suspicions. But perhaps this work can sort of stem some future ideas. And one of the things we'll want to think about whether it be in the UK or across in terms of European collaborations and worldwide collaborations, think about the outcome of pregnancy and atypical aHUS in the era of eculizumab. Surely the outcome should be better for these patients. We do actually need to understand some of the mechanisms of complement activation during pregnancy and at the time of delivery. And a couple of final little questions that went through my mind as I was writing this talk. We've heard already about patients who have atypical aHUS. They have treatment. Will they get a relapse in pregnancy? Why has their disease been triggered by one thing and not another? What about these women who will have these genetic mutations or carriers? They don't have disease at the moment, but is pregnancy a risk for developing atypical aHUS during lifetime? I'm not sure. I don't know the answer to that. I'm not sure we as a group know either. But it's something that's worth thinking about and think about how we can investigate this in the future. On that note, I would just like to thank all of the various clinicians, of course, patients all around the country who have actually helped gather the data to allow this project to take place. And finally, thank you to the team in Newcastle who have helped support me both in the laboratory work and, of course, in the clinical work that I'm presenting today. Thank you.
Yes.
So I have a question. You were talking about the next steps is maybe to increase the cooperation around Europe or the US, because for the statistics, 21 people is very limited. So you say that this is a possibility. Do you know how advanced is this kind of cooperation? How will you deal with that? And the next question, I was just wondering, sometimes you take 18 people and sometimes you take 21
Sure.
people. What happens with these 3 people that are missing?
To answer your last bit, it was just more about data completeness. So in terms of data completeness for genetic testing, we were actually able to get data from all of the 24 patients. But if we're talking about, for example, outcomes, and it's not clear from the notes that I had whether they had a transplant dialysis, I didn't want to include them and confound the data. So that's all that is. In terms of collaborations, I agree. 20 patients is not many, but you can see that if we were talking about individual triggers, you may have been talking about ones and ones and ones. But suddenly, even in the UK, we have 20. And if we can get, and we are actually in the process of some of the European collaborations thinking whether, for example, the French group who published their original data, they had around 20 patients as well. That's suddenly 40 odd, 50 patients, 100 patients. And we can suddenly start making a lot more sense of pregnancy as a trigger of disease and whether it is indeed a special case. And hopefully sort of learn more about those pregnancy triggers. And I think the European groups are very willing to share. It's just taking time, that's all.
Thank you.
Yeah, that data should, so we are indeed collaborating with all the European groups and we should have that data published within the next 6 months.
Thank you, that was brilliant. I think I am one of those red dots, so I basically would have been the person who presented at St. Helier
Sure.
6 weeks apart, and it's really beneficial for me to do the talk. I'm just wondering, is there any plans for making eculizumab like prophylactic in pregnancy for people like me who suffered the second flare-up of atypical aHUS at 6 weeks postpartum and ended up having sort of 1 month plasma exchange? Do you think if future pregnancies were a possibility that it would be something that you fall into a category where you can really be offered? Because I'm not on eculizumab now, but would it be something maybe in the future that would be considered as a sort of considered a high-risk pregnancy? People already did consent.
From my perspective as a researcher and as a registrar, so I'm not able to prescribe eculizumab, although obviously my bosses in Newcastle are. My thinking about this is that it is an unanswered question, that's the first thing, and that's one of the last questions I had clearly, that what is that relapse risk? We obviously do give it for us prophylaxis for transplantation, and there's probably a good opportunity to see if David, I think, is itching to maybe come up with a quick answer now?
No, I'm quite happy to let you flounder.
Fantastic. And this is all, of course, on video as well.
I think it is an individual question, and that it should be a discussion we have before anybody plans as to what we should do, and it will be discussed, reviewed in an individual patient basis depending on your risk, and we need to discuss it with you. But certainly there are certain people that we would want to do that with.
So I guess the first stage of meeting with your own clinician is at an obstetric level, and perinatal kind of counselling and saying, don't do this again, like, you must be crazy. So I kind of have to get beyond that as well, I guess, before.
Yeah, that's the usual reaction, but yeah, but I mean, it's a worrying time, and that's why you should definitely be looking to discuss that with your own obstetrician, nephrologist, and us prior to. Yeah, I think it's with everybody.
Did your research uncover any or suggest any connections between preeclampsia in pregnancy and aHUS, whether at the end of pregnancy or afterwards? Did you see any correspondence there?
As far as I could tell, in terms of these particular patients who obviously have presented with atypical aHUS at this time point, obviously preeclampsia was not anything that was confounding in terms of their maternal history. I think only one of them had preeclampsia during the course of this pregnancy. However, what we did find was that in those patients who had had a previous pregnancy, alluded to some of the fact that around half had had previous maternal complications, and preeclampsia, fetal loss, miscarriage were part of those, which suggested that there may be a spectrum of disease going from preeclampsia right the way through to atypical aHUS, and whether or not complement is important, we don't know the exact role of that.
So, if I can answer that. So there have been studies looking at preeclampsia to see, given the similarity of disease, whether people with preeclampsia do have complement mutations, and there are certainly a tiny percentage of people with factor I mutations that get preeclampsia. How many of them to go on to develop aHUS is not clear. So yes, in preeclampsia there's probably a small percentage that involve what you would understand as a complement mutation, but there are other studies suggesting that there may be smaller complement risks in preeclampsia.